Here we go. Hello, everyone, and thank you for watching this webinar on CPT and ICD-10 code pairing. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding webinar is illegal. The information in this presentation is for educational purposes. It's not intended to be legal advice. We don't provide legal services. I've made every attempt to make certain the information in this presentation is 100% accurate. However, it's not guaranteed. Let me tell you a little bit about myself before we get going. My name is Dr. Marty Kotler. I'm the president of Target Coding. I'm a chiropractor. I'm also a certified professional compliance officer and a certified billing and coding specialist. And I think that kind of makes me unique, right? Most chiropractors are not certified coders. Most certified coders are not chiropractors. You'll see as we go through this presentation, I've taken my experience, 16 years in the trenches treating patients, and then I combine that clinical experience with my coding expertise to show you how to bill and code properly, how to maximize reimbursement, how to make things a little bit simpler to digest, and how to make sure you're not leaving any money on the table. I've written many books and training manuals on chiropractic billing, coding, and documentation. I write articles to the major publications you see coming across your desk, like Chiropractic Economics, Dynamic Chiropractic, The American Chiropractor. I also write articles for the American Academy of Professional Coders. I'm a guest speaker at many state association conventions nationwide. By the way, if you're part of your state association that's looking for a speaker on compliance as it relates to billing, coding, Medicare, HIPAA, let us know. We typically can get a sponsor. We can come to your state association, put on a nice event, and there's no charge to your state association. Calendar's pretty full for the next 12 months, but maybe we could work something out after that. All right, so this webinar is on CPT ICD-10 code pairing. Let's start off with ICD-10. Let's start off with the diagnosis codes. So who is responsible for ICD-10? If you've been in practice more than 5 years, you remember when we went through that transition from ICD-9 to ICD-10. ICD-9 was around for about 30 years, from the 70s all the way till beginning of October in 2015. So who was responsible for ICD-10? It's actually a play on words. The World Health Organization, the WHO. The World Health Organization is responsible for creating and maintaining ICD-10. By the way, what does ICD-10 stand for? It stands for the International Classification of Diseases. We're up to the 10th revision. Believe it or not, there's rumblings around ICD-11. ICD-11. There's some information already that's been put out about ICD-11. You know, when we had ICD-9, it was around for 30 years. I do not think ICD-10 is going to be around for 30 years. I think ICD-11 will be coming around the mountain with less than 5 years. So ICD-10 began on October 1st, 2015. All HIPAA-covered entities must use ICD-10. So a little bit more about ICD-10. It has a format. It could have up to 7 digits. Some people think ICD-10 codes must be 7 digits. No. They could be as little as 3. Right there is an example of a 3-digit ICD-10 code. Dizziness, R42. Neck pain, M54.2. 5-digit example, M75.51. Right side shoulder bursitis. M25.462. Left side knee swelling. Believe it or not, all those numbers and letters, they actually mean something. The letter M, that means the musculoskeletal chapter, chapter 13 of the ICD-10 tabular list. 25 means joint disorder. Add 0.4, that means swelling. The number 6 means knee. The number 2 is left side. Yeah, they all mean something. That's how you build a code. And then we have a 7-digit code. Codes that begin with the letter S means injury, trauma. There's been some sort of injury, trauma. Those codes must be 7 digits, and they must end with an encounter, like the letter A or D or S. So there's an example: sprain of lumbar ligaments, initial encounter. Now, I mentioned with those a couple of extremity codes there, they have laterality. So in ICD-10, we have something called laterality, where the right side is designated by the number 1, left side number 2. So an example of sciatica on the right side is M5431. Left side, M54.32. Makes sense, right? We should have a right and a left, but there is no bilateral sciatica at the present time. There's a lot of things that I would change in ICD-10. For example, right here, why isn't there a bilateral sciatica? And I think we should have back one slide, M54.2, that should be neck pain on the left side. M54.1 should be neck pain on the right side. M54.3 should be bilateral neck pain. If I had my way, that's the way I would create this, but I don't. I make recommendations and suggestions. So in order for your services to be considered reasonable and justifiable, insurance companies, your scope of practice, your standard scope of practice require that your diagnoses have validity, they're compatible with your procedure codes, and are substantiated in your documentation. The reason for choosing a diagnosis must be in writing. It must be part of your plan of care and entered into the notes. I call it the what and why. You should understand the what and the why. What are your CPT codes? That's what you're doing. Why are your diagnosis codes? Don't choose a diagnosis code just because it feels right. Remember years ago, patients would come in back pain, pain down the leg. Oh, that's sciatica. I didn't do any orthopedic, neurological tests. I didn't do anything. I just labeled it sciatica just because it felt right. Don't do that. Make sure they're correct and they can justify medical necessity, or else you could have problems. You could lose a malpractice case. You could be audited and have to give your money back. So common diagnosis codes, subluxations, right? Subluxations, here are the subluxation diagnosis codes. Even though they don't say subluxation in the description, it says segmental dysfunction. These are the codes, at least the insurance companies want. For your cash patients, you don't have to use these. There are the subluxation complex codes. We also have traumatic subluxation codes. Remember the codes that begin with the letter S? Yeah, we have them for subluxation. I don't typically recommend using these. Then we have pain and symptom codes. Neck pain, thoracic pain, lumbar pain. Yeah, to me, these don't mean that much. But if you don't got anything else, according to the ICD-10 guidelines, if you don't got anything else, you just got signs and symptoms, then use them. A patient comes in with neck pain, and then, you tell them, okay, Mrs. Jones, I'm going to do a very thorough history. I'm going to do an exam. I'm going to take x-rays, maybe I'll do some blood work on you, and then when you come back, I'll tell you your diagnosis. Patient comes back on the next visit, you go, Mrs. Jones, I know what your problem is. You have neck pain. That the patient will probably be confused. Wait a second, Dr. Kotler, I told you I had neck pain. Well, that's your diagnosis, neck pain. Nothing else going on? Is there any type of disc issue, muscle issue, nerve issue? So it's good to dig deeper than just pain if you got it. Radiculopathy, yeah, radiculopathy. I consider radiculopathy a long-term treatment diagnosis code if I had to label it. M5412, very common. M5416, so we have radiculopathy codes. In my opinion, you don't need an MRI or a CT scan to prove that. We have sciatica. Make sure, put on your clinical hat. What's the difference between lumbar radiculopathy and sciatica? You should know that. You should do certain diagnostic tests. You see, today's webinar is about pairing. When you pair your codes, it's almost like food and wine. You want it to make sense. You want 2 + 2 to equal 4. If you're doing things 2 + 2 and it coming out to 3 or 5, something isn't matching. So put on your clinical hat. Why do you have lumbar radiculopathy? Why does the patient have sciatica? You want to be able to justify it. I'm going to show you examples of how to do that in a few minutes. So we have sciatica, M54.3. Don't use that. You have to get specific. Don't ever use M5430. Is it possible that the patient could have sciatica and you don't know, you don't know what's causing it, and you don't know where it is, So get specific, 31 or 32. Low back pain with sciatica, don't use M54.4 or M54.40. Those are actual bona fide valid ICD-10 codes, but if you report them, you won't get paid. Right side or left side, get specific. Yeah, now when it comes to the documentation, you might say, well, Dr. Kotler, I submitted a diagnosis to an insurance company of cervical radiculopathy, and they don't want to pay me. They're saying it's incorrect diagnosis. Well, I took a look at the doctor's exam. Everything looks normal. Orthopedic test normal, neurological test normal, good range of motion. How could you diagnose a patient with cervical radiculopathy with that clinical picture? You need to paint a picture. If you're going to use a diagnosis of cervical radiculopathy, your notes should say, here's where my clinical hat is coming in. I know I'm the code geek. I know I'm the insurance guru, but I also like to share clinical information that allows you to justify the codes you're billing. It's all about justification. You have to justify everything you're doing. You need to justify why you're using your CPT codes and why you're using your diagnosis codes. It's not only for insurance, malpractice, state board issues, for the patient. So if you're going to diagnose a patient with cervical radiculopathy, your note should say the patient has pain in the neck radiating into an arm. Do a little Jackson compression. I urge you, do a couple of orthopedic tests. Like I talked to some chiropractors and we don't even own a stethoscope. We don't own a reflex happer. We don't do any orthopedic neurological tests. I think it's a little dangerous. I mean, I understand being subluxation based. I get it. I understand. But your standard of practice in your state, even in managed care, there are some managed care plans, third-party administrators. You know what I'm talking about, like Optum and ASH, those plans. Some of them require that you do vital signs. If you don't do vital signs, you're violating the contract. So do a couple of basic tests. I'm not saying become a medical doctor. Just do the basic tests because I want to protect you. I want to make sure that you're doing things right. Check some reflexes when somebody comes in and says, I have pain in my neck, down my arm, I have some numbness and tingling, I have weakness in my arms. See if there's any myotomal weakness, dermatome changes. Sprains and strains, okay. These are good diagnosis codes. These codes begin with the letter S, and they have these encounters. So for example, the letter A means initial encounter. You're going to use that when the patient is receiving active treatment for the condition, and you're the first provider the patient visits. If the patient had an encounter, let's say a car accident, they went to a medical doctor, then they came to see you, that's considered a subsequent encounter. Let's say the patient has, in a car accident, they have back pain, and a few weeks later, they develop radicular pain down their leg, like sciatica or lumbar radiculopathy, then that's a sequela. That's a late effect of the original problem. You would use the letter S. And here's your sprains. Sprains take longer to heal than strains. Here's sacroiliac sprain. Now, how many sacroiliac joints are there? 2, right? There should be a sacroiliac joint sprain on the right and one on the left. If I had my way, that would make sense. We don't have that. Sacroiliac sprain, right or left or both, use the same code. Now, if you're going to diagnose this, again, back to ICD-10 and documentation, make sure you can justify your sacroiliac sprain, or else you could be made to look silly. You could lose a malpractice case. See, not only do I teach billing and coding and documentation and Medicare and HIPAA compliance, but now we also teach here at Target Coding. We also put on seminars on risk management, medical errors. So you want to, prevent medical errors, risk management. If you're going to diagnose a patient with any type of sacroiliac issue, I strongly recommend you do Yeoman's or Gainsland's. Those are gold standard tests. And we have them for a lot of conditions. I have a book that I wrote about 25 diagnosis codes of the 25 of the most common diagnosis codes, and the basic subjective ortho, neuro, chiro tests. Here's for piriformis. Here's one for carpal tunnel syndrome, Phelan's, Tinel's. Next, headaches. You're going to treat a patient with headaches. Okay, so you want to connect the dots here. Patient has, by the way, migraine headaches, the patient might have aura. That's the perceptual disturbance. Is it intractable or not intractable? You have choices there. Intractable means the patient has tried everything and nothing helps. The patient's not responding to conventional treatment. Status migrainosus, the patient, very rare, only about 1% of migraine sufferers experience status migrainosus. Means the patient's been hospitalized on IV medication because the headache has gotten so bad the patient's dehydrated, vomiting. So I'm just going to give you a quick example. If you're going to pair your codes, so here's the patient's diagnosis. Let's say it's the bottom one, G43.009, migraine headache without aura, not intractable, without status migrainosus. By the way, that was the most common one in my practice. So you're going to pair that with what? A treatment. So your treatment is a 98943 to the ankle. Whoa, that doesn't pair. When I talk about pairing, I'm talking about like food and wine. Like you pair red meat with red wine. So can you pair red wine with fish? That's typically not okay. So you're going to pair a chiropractic adjustment to the ankle, 98943, with G43009 with a migraine headache. That's bad pairing. I'll show you good pairing in a minute. Acute post-traumatic headache, 3 months is the cutoff point to make it chronic. Disc degeneration is also a very good diagnosis. If it's there, I consider it a long-term treatment diagnosis. In the neck, we have very specific levels. Disc disorder, disc displacement, yeah, these are your herniated discs, your bulge discs, complicating factors. I say report these. Let's look at this. Patient number 1 comes in just with low back pain. Patient number 2 comes in with low back pain, is overweight, is taking medication for anxiety, and it also has diabetes. Patient 2 is probably going to need more treatment. So you have these complicating factors and comorbidities. And now we have, there are many doctors I work with that work on, forward head carriage, upper cross syndrome, postural distortion, scoliosis correction. So here's a few: ligament disorder and cervical kyphosis, reverse cervical curve. How about abnormal posture, R29.3? So I've wet your whistle with diagnosis codes. Now we have CPT codes. Now let's talk about CPT codes. CPT codes are what you're doing. For example, a CPT code like 99203, that's a new patient exam code, right? That's what you're doing in exam. Why are you doing it? Well, sciatica, abnormal posture, neck pain, right? So you see where I'm going? I'm pairing my procedure codes with my diagnosis codes. Very important nowadays. So CPT codes, chiropractic manipulation, is a form of manual treatment to influence joint and neurophysiological function. You ever hear that? That's right from the AMA. The American Medical Association states that's what we do. We do CMT to influence joint and neurophysiological function. There are 10 regions of the body, according to the AMA, on CPT coding. The AMA owns the copyrights to the CPT codes, not to the diagnosis codes. So we have modalities now. Wait, let me back up. The chiropractic treatment codes, manipulation codes, adjustment codes, 98940, that's a spinal adjustment to 1 to 2 regions. 98941 is a spinal adjustment, 3 to 4 regions. 98942 is an adjustment to all 5 regions. And 98943 is the extremity, 1 or more regions. I feel like we got gypped on that one. We should get, the more extremities you adjust, the more you should get paid, right? There should be different codes for that, right? Yeah, I know you all agree. I'm preaching to the converted. Let's make it happen. I don't know how many of you listening to this, are you part of your state association insurance committee? Anybody listening to this a member of the ACA? Donate money, get in there. That's what I do. I used to have time. I used to call and stuff envelopes and do things for state associations because I had the time. I didn't have money when I first started practicing. Now, I don't have the time, but I have the money. I donate money to many state associations, to their PAC, the CPAC funds, to raise money so we can make changes. Don't we all agree that we should have more extremity codes? So we should get paid. If a patient comes in and I adjust the shoulder, that's nice. Next patient comes in, I adjust the shoulder and knee, both, all 10 toes and the TMJ. I should get paid more for that, right? And then we have modalities. These are more procedures, right? CPT codes, the top 3 modalities, 1 or more areas. These are not time-based. So you're doing traction. Why? You should have a good reason, right? What's your procedure? Well, we're going to do electrical stim. What's the purpose of electrical stim? It's to relax the tissue, increase circulation. That's what you're doing. Why are you doing it? Well, because the patient has certain conditions, back pain, sciatica. We have constant attendance modalities. Things change here. This is each 15 minutes. One of the most common is ultrasound, 97035. So the patient has neck pain. Going to do ultrasound? That could make sense. Shoulder pain, osteoarthritis, carpal tunnel syndrome, those match nicely. Now we get to therapeutic procedures. This is a manner of effecting change through the application of clinical skills. One-on-one contact required each 15 minutes. So for example, you're going to do therapeutic exercises. That's used to improve strength, endurance, range of motion. It's an active procedure. So that's what you're doing. Why are you doing it? It's got to make sense. Neuromuscular reeducation. What's the purpose of that? To improve balance, coordination. So if you're going to do neuromuscular reeducation to improve balance, coordination, kinesthetic sense, proprioception, what should the patient have a lack of when they come in? You got it. Balance, proprioception. Manual therapy, that's deep soft tissue mobilization, myofascial release. Why do you do that? To stretch the shortened connective tissue. So what should the patient have when they come in? Tight, shortened connective tissue, edema in the muscles, restricted motion in the joints. Therapeutic activities, that's to improve functional performance. Increase bending, lifting, reaching, carrying, throwing. So that's why you're doing therapeutic activities. What's the diagnosis? Sciatica? Headaches? Does that match? Patient needs help bending and lifting. Patient has difficulty reaching and carrying, throwing. And you're going to tie that to knee pain? Maybe. I mentioned time code, so hopefully you know that you should be using total time. So if you do 23 minutes of 140, you could bill 2 units. If you do another 23 minutes of another code like 110, can you bill 4 units? No, because the total is 46. 46 is 3 units. So make sure you total up the amount of time you spend doing all the time codes and then decide which code to bill. So now we're going to get into the pairing. I gave you a little basic information on diagnosis codes, ICD-10 codes. I gave you some basic information on CPT codes. That's what you're doing. And now we're going to combine them. Like you combine food and wine. I don't know how many of you have been to food and wine festivals. I love going to them. I like learning. I want to figure out how to have that maximum culinary experience. So back to the what and why. Your CPT codes are what you're doing. For example, you take x-rays of the lumbar spine. What's the CPT code? 72100. So that's what you're doing. You're taking x-rays. Why are you doing it? Because you want to rule out fracture, or maybe the patient has disc degeneration. That's your diagnosis code, disc degeneration, stenosis. That's why you're doing what you're doing. They should pair. They should match. If they don't, you might get audited and have to give the money back. So here are a couple of nice examples. What are you doing? Oh, you do mechanical traction. Why do you do mechanical traction? Have you ever been asked why you do mechanical traction? You should have a good answer. What's the answer? You want to stretch the spinal segments. You want to increase joint hydration. You want to make the facet joints glide easier. That's why you do mechanical tractions. But what are you doing? Mechanical traction. Why are you doing it? There you go. Cervical radiculopathy. The patient has pain in the neck radiating into an arm. One of the most common treatments for cervical radiculopathy is traction. See, that pairs beautifully. Mechanical traction, patient has lumbar disc, degenerated disc, and you're going to have the patient have some lumbar traction. That makes sense. M5136, that pairs beautifully. Now, what happens if the patient has ankle pain, sprained ankle? That's M25.522. So does that match with? No, mechanical traction could only be done on the spine. How can you pair that with an extremity diagnosis? Right? You see how that wouldn't make sense? Next, what are you doing? Oh, you're a doctor or you have a staff member that specializes in manual therapy, specifically myofascial release. That's deep soft tissue to stretch the connective tissue, get rid of acutely edematous muscles, help improve joint range of motion. Very good procedure, 97140, myofascial release. Why would you do it? There's a couple of good examples. Myofascial pain in the cervical region is M79.12. That matches so perfectly. That pairs amazingly well. Myofascial release with myofascial pain. That's one of my favorite ones. Patient has a herniated disc in the lower back. Yeah, myofascial release is appropriate. So you've heard of sommeliers. Sommeliers are wine experts, wine and food pairing masters. Yeah, wine expert, sommelier. I'm not a wine expert. I'm a coding sommelier. I'll pair your CPT codes and your diagnosis codes. Here's another one. Therapeutic exercises. Most of the doctors I work with bill for therapeutic exercises. It's used to improve strength, endurance, range of motion. So that's what you're doing. Why are you doing it? Diagnosis code neck. Of course, patient has neck pain, shoulder stiffness. The purpose of therapeutic exercises is to increase range of motion. So a patient comes in with decreased range of motion in the shoulder. That makes perfect sense. So those are examples of good pairing. You want bad pairing? Want me to show you what is wrong here? You're going to do mechanical traction? Okay, why? Right shoulder stiffness? Wait a second. That doesn't make sense. Mechanical traction is used for spinal problems, not for extremity problems. You don't use the anatomotor, the spinalator, the posture pump, the CBP. You can't use any of those traction devices on an extremity, so that would be wrong. How about an adjustment? Many of you do adjustments, right? Hopefully all of you do chiropractic manipulation. You do chiropractic adjustments. So if you do a spinal adjustment, let's say you adjust the neck, that's what you're doing, 98940, and you're going to pair that with a knee subluxation. Wait a second, the patient has a subluxation in the neck, and you want to adjust the neck, and you're using M9906 for the knee? That wouldn't make sense. So what are you doing? An adjustment. Why? The patient has subluxation, segmental dysfunction. See how that matches? All right, so just a few closing comments. Get proactive. Don't wait for the oil light to flash on your dashboard. Look at your codes. Make sure they make sense. Step 2, staff, make sure all the new patient forms get filled out properly. Step 3, doctors, make sure you review all the paperwork prior to the consultation. That's risk management. Step 4, review the policies from the companies you bill the most. Step 5, we just did a whole webinar on this, the what and the why. Make sure they match. Step 6, do a self-test on your SOAP notes. Make sure that you know what a medically necessary SOAP note looks like if you're billing insurance. Step 7, attend seminars, webinars. You should always keep learning on how to help more patients and how to improve your business. I'm a big fan of putting together a simple policy manual. This is so you don't have any disgruntled staff members accuse you of wrongdoing. Very important, in my opinion, to have a simple billing and coding policy manual. All staff members read it and they sign off on it. It's not for patients, really. It's not really for insurance companies. It's to make sure your staff behaves. Step 9, do regular meetings with your staff. Make sure that they are doing the right thing. If you have a billing company, by the way, target coding, we now do billing. If you have a billing company, do a spot check on them. Make sure they're not up coding or down coding. I see that all the time. You want to do all this so you could SWAN, that's my favorite acronym, sleep well at night. So I want to thank everybody for attending. Before we get to questions and answers, here's my contact information. You want to set up a consultation just to chat and talk and ask questions about your practice, or tell me what problems you're having, or you just want to find out about what services we offer, because we do more than just these webinars. We have training manuals and books. We do on-site trainings and one-on-one coaching. We have customized HIPAA and Medicare compliance programs that we put together for doctors. So we do all the heavy lifting. We have seminars all over the country and webinars that are CE approved, and our seminars are CE approved. This has been very popular lately. Just about every chiropractic magazine, journal you pick up, there's going to be an article on chiropractic compliance. Chiropractic compliance is HIPAA, billing and coding, and OSHA. Those are the big three. HIPAA is protecting patient information. OIG is billing and coding policies. And OSHA is basic, simple OSHA stuff. So $199 a month. It's not forever. That's just a one year. It doesn't take 1 year to go through this whole program, by the way. You could probably be done in about 3 months, and then we do the follow-up support. Hondas are great cars, right? I love Hondas. Hondas are terrific cars. We don't sell Hondas. We sell Mercedes. Ours cost a little bit more, but we do a lot more. And we have some very happy clients. Dr. Weinberg, Dr. Toke. Many doctors need help with ASH. We do ASH live trainings. You pick the day, you pick the time, and we will do a training for you and your entire staff. Put everybody into one room around one big TV screen or one large computer screen, and I will show you how to bill and code ASH properly, whether you're in network or out of network. The two questions we get regarding ASH is, Dr. Kotler, how do I get more visits paid by ASH? We'll take care of that. Next question, how do I get more cash out of my ASH patients? We take care of that. We take care of both. That's our main purpose of the training. Oh, and the CPT ICD-10 code pairing topic that we were just talking about, it's part of this book that I wrote. This is a book on the best CPT and ICD-10 codes to improve reimbursement. Chapter 2 is all about pairing. It gives you all the diagnosis codes for all the major procedure codes that you use. Here's an example, therapeutic exercises. It gives you the clinical rationale and then the list. And these, this is chapter 1 of the book. This shows you the codes that pay the most visits, the long-term treatment diagnosis codes. And yeah, this is in chapter 3 of the book. This is the codes and their ortho-neuro-chiro tests to support it. So this is your clinical tests and findings to support the most common diagnosis codes in chiropractic. You'll see there's brachial syndrome, right? Cervical brachial syndrome. You should do a little rights, ATSIDs. Remember those? Oh, the book also has cheat sheets. So at a quick glance, you could check off the codes that pay for the most visits, hand it to your staff or your billing company. We also do a boot camp. Target Coding has a CA boot camp. I do a little bit of these. These are run by Natasha. She's been a CA, an office manager working for Target Coding. She's a licensed massage therapist. She's been a front desk CA, a back CA, and insurance. Her and Brandy Brimhall run the CA boot camp. We've gotten rave reviews. They're really kicking butt with this. I contribute a little bit. We have 4 modules. Module 1 is front desk and patient relations, where we go through new patient onboarding, intake forms, financial policies, how to handle the most over-the-counter patient objections and questions. Billing and collections is module 2, how to complete forms, what auditors look for, revenue cycle management. Module 3, I get involved with module 3. I go over the basic anatomy, how CAs can do the SOAP notes, and how CAs can apply the therapies. Many states in the country allow CAs to apply the traction, the stim, and oversee exercises, so we go through that. And in module 4, it's all about compliance, OSHA, HIPAA, how to get started. Doesn't have to be overwhelming. How to be an effective, respected office manager and be able to supervise a large staff. Oh, and I mentioned we now do billing. Let us know if you are tired of hiring and firing and hiring and firing and hiring and firing your office billing manager. It's time to outsource. Overall, I think you're better off doing it in-house. We basically recommend do the billing in-house because we get that question all the time. Should I do it in-house or hire a billing company? I typically say, do the billing in your office. But Dr. Kotler, I hire a billing person and then she quits. I hire another one, then I fire her. There's that constant turnover of staff. Then you need to use a billing company. Or I have a client, very busy practice. He's 100 a day. He has a billing person. She's great. She's terrific. She's wonderful. They do the billing in-house. It's just overwhelming for her. She's constantly on the phone and she's constantly trying to catch up. It's just become too overwhelming. So even though he has an amazing in-house billing person, he's now going to do the billing, outsource the billing. Let us know if you're interested. Oh, we also have forms. We have a whole bunch of forms. I've written probably about 200 forms and templates and letters of medical necessity. I put together my 75 greatest hits. And here they are, new patient forms. Now, you could have the best software in the world, Genesis, ChiroTouch, Eclipse. It's great. You still need forms. You still need fight back letters. You need letters of medical necessity for back brace or pillow or taping or laser. We got it. You need pushback letter. You're getting denied because you do a re-exam or manual therapy on the same day as an adjustment. Your software doesn't have that built in. We have a whole bunch of appeal letters, all the HIPAA forms, sample soap notes, sample PI reports and radiology reports, consent to treat minor. The check goes to the patient. What do? We have a great form for that. Financial policy forms. Let us know if you want to buy our forms. They're available right now on the website. We can email them to you instantly. Some doctors say, Dr. Kotler, I don't need forms. I don't need a HIPAA program. I just want you to check my soap notes. Fine, bring your soap notes in for a checkup. We have something called our chart audit review and fee schedule review. 5 charts, we'll scrub them, we'll tell you what we like, what we don't like, and you're on your way. We'll probably find money you're leaving on the table. How do we know that? Been doing it a while. You know that farmer's insurance commercial? We've seen a thing or two, right? What is that? We know a thing or two because we've seen a thing or two. Same thing here. There have been quite a few doctors. I've provided them with one CPT code that they didn't even know that they can bill. It's added up to $10,000 to their practice. Oh, we're also doing a cruise seminar. Many of you listening to this were on the first one. Well, we have our second annual target coding cruise seminar coming up in April. 10 CE credits. So yes, there's a little bit of learning. We broke it up into 2 days. Day 1 at sea, there'll be a seminar from 8 in the morning till 1 p.m. 1 p.m., go eat lunch, go to the pool, go get a margarita, go relax. Then we're going to be cruising around a few islands, and then there's going to be another sea day. Got to get up 8 o'clock to 1 o'clock. There's your 10 hours. It applies towards record keeping, coding, risk management. It's been approved in over 30 states, and we also got approved for acupuncture. We now do acupuncture seminars, and our seminars are approved for, in chiropractic, it's called CEUs. In acupuncture world, they're called PDA points. So the seminar has been approved for 6 acupuncture PDA points. Oh yeah, here's part of the crew. That was on last year's. We also have videos. We sell videos. We have 11 videos on our website, and we also do HIPAA compliance manuals. So again, I want to thank everybody for attending. I hope you learned a lot. Let's go and take a look and see what questions have come in.